since the course is a basic course, so I'll not be going into details of the surgery. So we'll be discussing only the characteristics, the risk factors, and the prognostic factors for traumatic retinal detachment, as well as categorization. I have no financial disclosures to disclose. So Kuhn et al. In 2002 gave a terminology for all kinds of trauma, so that it becomes a universal thing and everybody follows the same. The injury can be divided into a closed globe and an open globe. The closed globe can further be classified as contusion or laceration. Laceration is always a partial thickness here. In an open globe injury, the laceration is further classified as penetrating when the wound is only one side of the globe, the perforating when the entry and exit wounds both are there, and an intraocular foreign body is present along with the penetration. Amongst all, only partial thickness lacerations in closed globe never cause a retinal detachment. All others can cause a retinal detachment. Most common cause of a retinal detachment of a trauma is a closed globe injury. This is not because the closed globe injury is more predisposing to retinal detachment, but the number of cases of trauma are more with blunt injury rather than a penetrating wound. So characteristics of traumatic retinal detachment include that they are usually rhegmatogenous. These retinal tears generally occur at the time of trauma. Closed trauma is more frequent, as I already said, although the greater tendency is in open globe injury. Usually there is long interval between trauma and retinal detachment, as well as long interval between retinal detachment and presentation. Generally, the traumatic detachments, specifically in closed globe injuries, present very late, and they have old retinal detachments. Sometimes patient may have multiple demarcation lines on presentation. Now, why is it important to diagnose the retinal detachment as a traumatic case? First of all, to prognosticate, as trauma may be associated with other things like angle recession, zonular weakness, retained intraocular foreign bodies, traumatic optic neuropathy, and traumatic maculopathy, which may reduce a final visual outcome even after the surgery. And secondly, it can be a medico-legal case which you have to handle later on. So closed globe injury is also further divided into a direct injury, when the injury is directly onto the globe, and an indirect injury. We generally do not consider an indirect injury as a main cause of the retinal detachment. Sometimes patients say the trauma was on the temporal side of the head, but retinal detachment can occur with even indirect blunt injury, as during the time of injury there are intraocular currents which are sufficient to cause a retinal tear, and later on can lead to retinal detachment. Traumatic detachments constitute around 6 to 19% of the cases of total rhegmatogenous detachments, generally common in males, and median age is very less. It's generally seen in younger population as compared to non-traumatic RDs. Coming to pathophysiology in blunt trauma, Wu and Peters et al. Way back in 1987 had described that retinal strips containing retinal vessels are significantly stiffer than strips that have no vessels. That means they are not having elastic tunica. Fovea is avascular and the vitreous base contains very few vessels, which creates a differential stiffness which forces the most elastic ones, that is the vitreous base and macula, to deform more and possibly reach the breaking point earlier when stress is applied. Thus, generally traumatic breaks are seen at near the ora, or you may get a traumatic macular hole. Tommaso Rossi et al. In 2012 had documented this by their experimental design, where they have used a ball bearing to induce a trauma, and they have assessed the strain rates inside the eye. It was an artificial eye model based on finite element modeling, and they have described that negative pressures are associated with multi-axial strain, and high strain rates can tear and detach the retina. Differential retinal elasticity explains the higher tendency towards tearing the macula and vitreous base, which I have already explained. And as you can see, the peak negative pressure and peak positive pressure, the negative pressure is created at the time of impact, and positive pressure is created when the bearing ball comes back, is highest at the macula and vitreous base as compared to the equator. Thus the breaks are generally seen either at macula or at the vitreous base. As we all know, that dialysis is most common type of break found in traumatic retinal detachment, and even around 69 to 83% of dialysis are caused by trauma as compared to 6% in non-traumatic detachments. Presence of a dialysis and a avulsion of vitreous base is generally pathognomic of traumatic retinal detachment. Supranasal dialysis are also considered pathognomic location of dialysis for post-traumatic detachments. However, 50% cases of inferior-temporal dialysis are generally associated with trauma. Patients may have giant retinal tears, may have tiny breaks near ora serrata. Pathogenesis I have already told. Sometimes a direct trauma can lead to chorioretinal necrosis at the site of trauma. And in very few patients may get retinitis cleptoria, which is actually indirect trauma to the globe by passing when a object passes with a high projectile velocity abutting the ocular coats. So as you can see, this is a contusion injury. You can see a Berlin's edema near the posterior pole. You can see some amount of hemorrhages. In this image, we are not able to capture the break. This is again an example of Berlin's edema after blunt trauma. These are traumatic retinal breaks. You can see multiple breaks with surrounding subretinal fluid. This is a wide-angle image of a retinal dialysis. You can see that there is splitting of the retina at ora serrata. This is an example of retinitis cleptoria. You generally get a chorioretinal scarring with intraretinal hemorrhages. In these cases, later on they may go and develop tractional retinal detachments. Very rarely they develop rhegmatogenous detachments also. And this is a case of giant retinal dialysis post-traumatic. Now to assess the visual outcomes, ocular trauma score has been described so as to prognosticate a case while operating, which is very important because we have to tell the patient what outcomes are we going to give him after the surgery. You can see the most important thing is the presenting visual acuity. So the outcomes depend on the presenting visual acuity, and all other are against the good prognosis. Like if the patient has lobe rupture, the patient is given minus 23 points. If he has endophthalmitis, perforating injury, retinal detachment, and RAPD, these are subtracted from the presenting visual acuity, and we give a score based on the sum of raw points. And as you can see, if the visual acuity is good and the patient has nothing else, the amount of success, the visual acuity of more than 20/40 is seen in more than 95%, 94% patients. So calculating an ocular trauma score at your initial presentation is the most important way to telling the patient how much vision is expected after the surgery. This is an example of open globe injury. Coming to open globe injury, you can see a vitreous and retinal incarceration in a perforating wound, and these cases are very difficult to operate. Even if you attach the retina, later on these folds will never go, and since it's involving the posterior pole, the visual prognosis is very guarded in these cases. Generally, open globe injuries are also associated with corneal scars, aniridia, aphakia, hypotony, endophthalmitis, macular holes. And generally the detachment in open globe injury is complex. By complex we mean that they are associated with tractional components. They may have choroidal hemorrhage, they may have subretinal bleeds. So the RD after open globe injury is basically because of the direct trauma to the retina, causing a retinal break, and sometimes a tractional retinal detachment can occur because of this blood and vitreous can lead to fibroblastic proliferation over the retina. This is a study by Strajewski et al. Where they have shown that 1/3 of these patients with open globe injury go on to develop retinal detachment, and you can see on Kaplan-Meier survival estimate that nearly 27% or nearly 30% patients are getting retinal detachment immediately, and 50% of them are getting within first week, and 72% of the patients are getting in the first month. So they need to be monitored very closely. Now whom should we monitor? So they also gave this RD OGI scoring where we can estimate that this patient will get a retinal detachment in near future. So they've again considered only 3 points: the presenting visual acuity, the zone of injury. The zone 1 is corneal injury, zone 2 is within 5 millimeters of the limbus, and zone 3 is posterior to 5 millimeter of the limbus. So if a patient with zone 3 injury is presenting with vitreous hemorrhage and a light perception vision, there is 86% of chance that patient may have retinal detachment or will develop retinal detachment. So again, calculating this RD-OGI scoring is very important in your clinics, and you can keep patient under very close follow-up, or sometimes you can go for a prophylactic vitrectomy or immediate vitrectomy in these cases. Now, timing of vitrectomy in these cases is very important. So there are two schools of thoughts. One says that you should go within 3 days, another says you should wait for 1 to 2 weeks. The advantages of going in within 3 days, as I already told, that the vitreous, the lens matter and the hemorrhage, they are the promoters of fibroblastic proliferation, and studies have shown that this proliferation starts within 4 days of injury. So they say that removal of this will prevent further proliferation, PVR later on, the risk of redetachment decreases and the success increases. However, another school of thought says that immediately the uvea is very congested at the time of surgery, so it will increase the risk of massive hemorrhage during the surgery and maybe in the post-op. The likelihood, being a retinal surgeon, the posterior vitreal detachment in young patient is a little difficult task, so this might occur spontaneously. And if the patient has hemorrhagic retinal or choroidal detachment, it may liquefy and it's easy to remove. Most of these patients have poor media, so ultrasound is a very important investigation to assess the posterior segment. You can see a elevated optic disc with chororetinal thickening suggestive of massive hypotony. This is an open funnel retinal detachment. You can see a suprachoroidal hemorrhage with overlying retinal detachment, and this is a closed funnel RD. So, a study by Andreoli et al. Has shown that ultrasound is 100% has positive predictive value for diagnosing retinal detachment. So, before going to further surgery, you know that patient is retinal detachment. So, the various predictors have been described for assessing post-operative visual acuity after these surgeries. The most important is the presenting visual acuity, which you have to understand, and is higher the zone of injury, that means the posterior injuries are more predisposed to have lesser visual outcome because they involve the posterior retina more. Coming to few slides for retinal intraocular foreign body, I'm not going into details of intraocular foreign body, but yes, they constitute around 40% of open glob injury, and they may have retinal detachment is generally seen in up to 20% of cases with intraocular foreign body. Now, the most important thing I just wanted to highlight is that even if you remove intraocular foreign body, the post-operative retinal detachment can occur in up to 36% of the patients. So, this is the most important, and this generally occurs within 4 months of primary surgery. And the risk factors for post-operative retinal detachment, if the size is more than 4 millimeter and at the presentation patient end off, you must keep him under close watch that he has around 30% chance of developing retinal detachment even after surgery. So, a study done at our center has shown that planning a scleral buccal or a scleral encerclage at the time of foreign body removal reduces the post-operative retinal detachment to 6.6%. Just to conclude, correct diagnosis and characterization is very important because generally there is delay in presentation. Prognostication of the other eye is important because traumatic retinal detachment generally do not involve the other eye, and patient is at no risk of developing retinal detachment in the other eye as compared to patient who has primary retinal detachment in one eye. And it's of medical local importance, and long-term rehabilitation required in these cases because of involvement of anterior to posterior, most of the structures are involved. Thank you.